department and in the neuroradiology group together with Dr. Manar and Dr. Muhammad Tiba and Dr. Jihad. I'd like to thank them very much for their lectures. Thank you very much. We are moving now to the last two talks will be a reflection of what we have in the past few months, that we have a new name for our department, which we are very glad that we did convince the council of our school, then the council of the university, then the higher council of the universities to change the name of our department to Department of Diagnostic and Interventional Radiology and Molecular Imaging. So molecular imaging will be part of our next talk, and we're glad that we are the first department in the Middle East and Africa to have this name, wishing the other departments to follow us, inshallah. Thank you very much. We now, I don't see Pasant. Where is Pasant? Ah, okay. Okay, Pasant will present the next lecture with the APT, which is amide protein transfer imaging in brain tumors.
Okay. Good afternoon, everyone. Today we're going to talk about APT imaging in brain gliomas. Gliomas are the most common primary tumor of the central nervous system. The ability to discriminate between high and low-grade gliomas is of clinical importance, as the prognosis and the standard management is different substantially. Misdiagnosing high-grade as low-grade tumors can lead to insufficient and less aggressive treatment. The current gold standard way for glioma diagnosis and therapeutic decision depends on histopathology, as well as the molecular profile and genetic information. However, the histopathology results depend on biopsy or surgical resection, which is not only invasive, but it also depends on the tumoral, affected by the tumoral histological heterogeneity. It's liable to sampling errors, and in some cases, it's hard to have a biopsy. It can be due to a deep-seated lesion. The patient may be not fit for biopsy, or the patient even may refuse it. MRI is usually the imaging study done preoperatively for diagnosis. High-grade gliomas usually show moderate to strong enhancement, while low-grade gliomas show no or mild enhancement. However, about 50% of high-grade gliomas shows no enhancement at all, and 20% of enhancing glioma were histopathologically proved to be low-grade gliomas. Accurate grading for glioma is still challenging with traditional MRI imaging. MRS usually increased protein usually indicates higher cellular turnover. However, its accuracy is erratic because the selection of the voxel is dependent on the operator judgment and often represent the entire portion of the tumor. Most recently, FDA approved amide proton transferase, APT imaging, has emerged as a powerful technique to utilize the chemical exchange saturation transfer effect between peptides, small protons, that's what peptides mean, and bulk water. Because of the presence of overexpressed peptides in tumors, APT imaging has showed its unique efficacy in tumor identification and characterization. Some studies have demonstrated capability of APT imaging in tumor identification, characterization, as well as grading and IDH-stated differentiation. High-grade tumors usually have increased cell density, thus having increased proteins and peptides in tissue, increasing the APT signal. So what is APT? Just a small brief about it. Usually in our body, we have a large number of water molecules and small number of protein molecules. The MRI signal is usually present due to the presence of the hydrogen atom, either on the water or protein molecule. Usually in our body, because the presence of high water molecule, it leads to high MRI signal. Yet, the protein concentration in low percent doesn't produce any measurable signal. Usually, these two molecules, the hydrogen atom on the water and protein exchange together without affecting the high signal on the MRI due to the water signal. On applying long saturated pulse with the same resonance as the protein, this will lead to alignment of the hydrogen atoms on the proton, the hydrogen small proton on the proton atoms with the same alignment of the magnetic field, while the water molecule will remain unchanged, leading to its high signal. At this time, these small hydrogen protons will be null with no signal at all. As we mentioned earlier, there is usual continuous exchange between the hydrogen atom on the protons and the hydrogen atoms on the water molecule. With suppressing of this hydrogen atom, this will lead to decrease of the water signal in a proportional concentration to the protein, thus reducing the water signal can be measured on the APT sequence. APT images are usually presented as color maps created by using an asymmetrical calculation. So the presence of APT is shown as a positive color signal ranging from blue to red color. Also, quantitative imaging can be achieved. Let's then discuss the role of APT imaging in brain gliomas. The first role of APT is glioma grading. As we mentioned earlier, the presence of peptides or protein concentration results in increased cellular density in high-grade gliomas. Usually, high-grade gliomas harbor higher APT signal intensity compared to low-grade lesions. As we can see here, there is a case of diffuse astrocytoma IDH mutant seen showing a lesion which is high signal intensity on T2, low in T1 with facilitated diffusion, and more or less low signal intensity on APT, especially if we're comparing it to this glioblastoma lesion, which is wild type. Of course, according to the WHO 2021 classification, each GPM should be wild type. There's no mutant type for it, showing increased signal intensity on the APT images. Glioma grading, the APT has the ability to differentiate between low and high grade gliomas by sensitivity of 94.4% and specificity of 77.8%, with cutoff value of 4.1. Also, some papers have proved that it has the ability to differentiate grade 2 versus grade 3 tumors by sensitivity of 70% and specificity of about 92%. It can differentiate grade 3 versus grade 4 by sensitivity of 100% and sensitivity of about 82%. And it can differentiate grade 2 from grade 4 by sensitivity of 100% and specificity of 100%. The second role of the APT is to identify the genetic markers in glioma. Usually in our team practice, we depend on T2 flare mismatch, which usually achieves sensitivity of 88.9% and specificity of 86.7%. Also, we can depend on mega spectroscopy, where the presence of 2-hydroxyglutarate indicates IDH mutant type. Finally, we can talk about our CEST or APT imaging. As we can see here, these are two cases of, these are two different patients with high-grade tumors, where one of them is IDH mutant and the other one is IDH wild type. As we can see, there is low APT signal on the IDH mutant lesion with increased APT signal on the IDH wild type. It has the ability to differentiate between IDH mutant and wild type by sensitivity of 88.5% and specificity of 96%. Actually, most of these papers were done on histopathologically proved high-grade tumors, and this value doesn't accurately detect the possibility of IDH mutant or wild type in low-grade gliomas. Also, the APT has the ability to differentiate between active gliomas and treatment effects. APT signal is higher in recurrent gliomas than treatment-induced changes, where, as we can see here, a case of frontal lobe heterogeneously enhancing lesion showing increased APT signal on the APT color map. It has proved that additional value of APT on diffusion and perfusion significantly improved diagnostic performance of detecting recurrent gliomas than treatment-induced changes. As we can see here, that was a case of patient with high-grade glioma submitted to radiotherapy, showing regular patchy post-contrast enhancement with low signal on APT images. On follow-up 5 months later, that was proved to be pseudo-progression with no evidence of recurrent tumoral tissue, assessing the availability of APT in differentiating the tumor from treatment changes. It has the ability to differentiate by sensitivity of 84% and specificity of 72.7% with optimal threshold of 2.11. This showed higher accuracy than the ADC, fractional isotropy, and cerebral blood volume. So here are some cases from our routine work. First case is a 57-year-old male patient presented with gait disturbance and headache. The lesions show predominantly low signal intensity on T1, high signal intensity on T2 of mixed solid and cystic component. It shows contrast enhancement, strong contrast enhancement, increased perfusion, increased choline to create ratio with increased lactate peak. And as we can see on our APT image, that's one on the right, there is increased APT signal on the tumoral tissue. But just be aware not to measure the cystic part of the lesion, because as we mentioned earlier, water has the highest APT signal in body. So if you measure the cystic part of the lesion, it will lead to false measurement to the APT. So even the salt part, so we're just discussing salt part of the tumor. Here's another case of histopathologically low-grade glioma of a 33-year-old male patient presented with headache, showing high signal intensity on T1, on flare-weighted images with facilitated diffusion, no evidence of increased perfusion, and low APT signal. That was another case of high-grade glioma where it is seen showing increased uptake on the APT weighted images, mild post-contrast enhancement with facilitated diffusion and no increased perfusion, and this show the advantage of APT over other modalities in some cases to assess the grading of the tumor. That's another case of a low-grade glioma in the bones that was diagnosed through follow-up and by radiological imaging feature and long-term follow-up. Biopsy was not achieved in this case because it was deep-seated. It have conventional low imaging features being predominantly low in T1, isotope high in T2 and flare, no diffusion restriction, no increased perfusion, and also the APT signal confirmed our finding with no increase in the APT signal on the color map. That's our last case of a follow-up case of high-grade glioma where all our conventional imaging showing that it is high-grade being predominantly heterogeneous or being mainly heterogeneous on T2 weighted images showing post-contrast enhancement, which is patchy and a little bit ring enhancement. It's been surrounded by pathogenic edema, show true diffusion restriction, increased perfusion, and also increased APT signal intensity. That was the MRS of the case showing increased choline-crat ratio with decreased NAA and increased lactate. The follow-up after 6 months show progression of the size and the radiological features of the tumor, and it was also proved by our APT signal. So to sum up, APT is a recent imaging technique that produce image based on amide protein concentration in tissue. The adding of the additional value of APT to our multiparametric MRI studies significantly improved diagnostic performance for grading of brain gliomas as well as differentiating post-treatment changes from recurrence, which also have added value in patients with renal failure as it doesn't require any contrast and it usually takes less than 5 minutes as a sequence. APT has an additional role in determining IDH mutant versus wild type, which is important assessing the prognosis of WHO grade 4 tumors according to the recent WHO classification. Thank you.
Thank you, Dr. Pasant.